Welcome to this iWorld live event. I have an entirely live person here. I'm glad that you're joining us, John Berdahl. I'm excited for what we're going to be talking about today. These are cross-linking pearls. Why don't I have you just sort of flesh this topic out? I already know I've got questions that I want to ask you.
Yeah, you bet. So cross-linking is important. We all know that it slows the progression, if not stops the progression of keratoconus. But there's some challenges to it. Which are the right patients to treat? How do we get it paid for? Is it enough just to stop it, or can we change the shape of the cornea so people can actually see better?
Now, we're going to be talking about progression. But I know that I'm already, you're going to think that I'm wacko here, more wacko than you already think. I have a question about the premise of progression itself. And the reason is this. If we look at what the data were that were submitted to the FDA that resulted in approval of cross-linking, they were data about things like reduction of Kmax and all of these important clinical things. Those are important clinical things. Why do we even have to demonstrate progression? Don't we want Kmax reduced for our keratoconus patients generally?
If you're wacko, I'm alongside you, because I totally agree with you. Yes, we want flattening of the cornea. And, you know, so many things that we do are an artificial constraint of how a study was designed. Because how the study was designed leads to the label leads how it's talked about, and how it's talked about leads to what we believe. And so I'll give you an example of it. 400 microns. We say we can't cross-link somebody less than 400 microns. There's not data to support that. That was a safety endpoint in the study so that they didn't have a problem, and then somehow it becomes dogmaticized in our minds. So yes, I totally agree with you. Flattening in and of itself is a reasonable reason to do cross-linking, even if you can't prove progression. But the way the study was set up was to show that it slowed the progression, and that's what the label says, and that's what the insurers follow most of the time.
So let's talk about progression. Progression, by definition, means more than one data point. But are there clinical circumstances in which a single data point is evidence of progression?
So if you have a 20-year-old that has keratoconus, they weren't born with keratoconus. They have progressive keratoconus. And look, we took an oath to do the right thing for the patient in front of us. Not an oath to the FDA, not an oath to an insurance company, a sacred oath to do the right thing for the patient in front of us. And if that 20-year-old has keratoconus, it's progressive keratoconus, and let's find a way to do the right thing for that patient. Now, most of the time you can detect progression. A half a diopter change in myopia on the refraction is enough, but you can also look at topographic changes and changes in astigmatism. So usually you can find it, but that's a secondary driver for me. The first driver is do the right thing for the patient.
So if it is a patient for whom we want to be able to demonstrate progression over time, you know, so it's longitudinal data, what are the sort of data that meet clinical criteria for progression? You mentioned myopia. What else?
Yeah, so half a diopter progression of myopia, 1 diopter in steepening on the Ks on topography, 1 diopter of change in astigmatism on the topography. All of those qualify.
So on that theme, if a patient, so I know I keep on harping on the idea of defining progression on a single visit, but if a patient comes in and says, these were my glasses from 3 years back, and I saw well with them, and I don't now, and you manifest them,
yeah,
and things are changed from those glasses, can you count that as sort of data point 1?
Yes. Yeah, no problem at all. There's a change in a refraction there, and so yes, no problem.
Okay, so let's talk about adoption of this technology, and I'm going to guess that the biggest barrier to adoption has been reimbursement. So how has that landscape changed? How has insurance coverage changed?
Historically, that has been the biggest challenge, and it's going away. I would say that in our region, we were just talking about this with my billing manager, 90% of insurers are covering it now, and the last ones are going to fall. So it's less of an issue now. It's just navigating the system, but ultimately many of these places have a policy in place. But what I've kind of learned to enjoy doing is talking with medical directors on a peer-to-peer review, and I'll send them the 20 papers that support it, and then I'll call them up and say, did you read those 20 papers? And they say, no, and I say, let me make sure I get this straight. You're going to deny coverage without even looking at the literature for this patient that I'm looking in the eye that I know this is the right thing to do for? And then they say, hey, let me take a look. And I say, we'll talk in 2 weeks, and they don't read it then, but by then it's so much work they just want to cover it. So we can create more work for them like they do for us and actually get the right thing done for our patients.
That's really smart. I like that. Maybe it's the authoritarian, misanthropic side of me this appeals to, but it's working for me, man. It really, it's a big side. John, cross-linking is undoubtedly wonderful. It's wonderful for the patients. It's not a panacea. Is there a role to combine other technologies with cross-linking?
Good question. I think that there is. And so one of those is a scleral contact lens. By the way, avoid rigid gas perms that are small. Every time you blink, it rocks on the eye. It's like a little miniature rub. Get a scleral contact lens or get comfortable with somebody in your region that does scleral contact lenses. That's one. Two, in the future, maybe topography-guided treatments that may normalize the shape of the cornea with the excimer laser. But where we're finding a lot of success actually is with Intacs. And so, you know, Dick Lindstrom taught me this. He said, you know, what I've been doing is if the patient can't see better than 20/40 best spectacle corrected, their glasses can't get them better than 20/40 or 20/40 or better, I put in an Intacs. And our results have been really remarkable. We get a lot of patients that don't have to wear their contact lens 24 hours a day. They can get into a pair of glasses. So I think of cross-linking plus Intacs as a way to get them some relief from scleral lenses and into glasses sometimes, and it's worked really nicely.
John, this is great stuff. This is it's important for our patients, but our patients are not going to benefit from procedures that we don't offer. So I think that even more so, this is valuable to provide context for clinicians who can offer this therapy too. I want to thank you, as always, for being not only so smart, but for being so very generous with your time. And I want to thank you, our live viewing audience. I learned a ton from John, as I always do, and I know that you did too.
Thanks a bunch.